Top Med Talk. I'm Monty Mythen, Editor-in-Chief of Top Med Talk, and welcome back to Journal Club. So I've chosen an article from Anaesthesia and Analgesia, the November edition, November 18, volume 127, entitled The Implication of Major Adverse Postoperative Events and Myocardial Injury on Disability and Survival. It's a planned sub-analysis of the ENIGMA-II trial. First author is Scott Beattie, and it's on behalf of the ENIGMA-II investigators. So the ENIGMA-II trial was an evaluation of nitrous oxide in gas mixture of anaesthesia, ENIGMA-II. It was an international randomised trial of 6,992 non-cardiac surgical patients. They were all over the age of 45 and had moderate to high-risk surgery. The primary outcomes was mortality within 1 year postoperatively, but they also defined 4 separate types of postoperative adverse events. Now, this paper is particularly focusing on major adverse cardiac events, which are referred to as MACE or MACEs, and that included myocardial infarction, cardiac arrest, myocardial revascularization with or without a troponin elevation. And they put in there a sub-definition about what a myocardial infarction is. But they also considered a cohort of patients who experienced major adverse postoperative events, including unplanned admission to intensive care, prolonged mechanical ventilation, wound infection, pulmonary embolism, and stroke. They then went to look at whether or not the patients in those various 2 groups did or did not have a postoperative troponin evaluation. And what they conclude at the end of it is whether it's a MACE, the major adverse cardiac event, or the MAPE, which is the major adverse post-operative event, that they occurred with similar frequencies and both affected survival to a similar degree. Now, I'll come back to the detail on that in a second. But I think what this is looking at and trying to pick apart, and we've discussed this quite often recently on Top Med Talk, and it's quite a hot topic, is the relevance of an isolated troponin rise, whether or not that is a prodromal sign for having a major cardiac event that causes death, or whether the things that we see much more commonly postoperatively, like wound infections, pulmonary emboli, prolonged mechanical ventilations, are equal contributors to subsequent death, or whether there's an overlap of those 2 circles. So Desiree Chappell, US anchor, is on the phone to discuss this. We recently went over this quite a lot of detail with Mike Grocott in the METS trial, and that's gone out in Journal Club fairly recently from Top Med Talk. So that's a lot. I've read this paper a number of times now. This is quite a lot to take on board, but I think I'm sort of getting there. I think it reinforces, in one way, the sort of thing we see every day of the week, that there may be a lot of myocardial injury going on, i.e. troponin rises, but what we're seeing on our post-operative intensive care unit wards, etc., is a lot of sort of pneumonias and GI tract dysfunction and acute kidney injury. Is that right, Desiree?
Sure, I think that's a fair comment. I mean, that's when you were going through the MAPE thing. I mean, definitely the METS trial had talked a lot about that, and maybe clarifying it. I still, with the troponin increases and things like that, is what I'm trying to wrap my head around.
Well, if within the paper, if you go to Figure 2, which is the Kaplan-Meier survival analysis, I think that's where you get the takeaway message. So it's got the mortality rate percent, and it's got the months after surgery, and it's got the 1 year mortality analysis. So each of the lines as they rise up, the mortality rate over time is increasing out to 12 months. And the lowest line, which has the lowest mortality, is if there were no adverse events recorded in the trial. The next one up is an isolated troponin elevation, i.e. they've recorded the troponin rises in all the patients, and just by having that, it would appear to be silently, does increase mortality. Then the next one up is the MAPE without a troponin rise. So getting up towards about 15% mortality rate at 1 year is a major adverse event, one of these major adverse postoperative events, the infections, the strokes, the things we've talked about before. Now, just above that is the MACE, which is the major adverse cardiac event. But remember, that's the actually ending up with what appears to be a heart attack or needing to be revascularized. And I think we'd accept the fact that if we saw that, then that would have a high mortality rate. It's how commonly that happens is the big question. But by far the highest mortality rate is up to over the sort of 25% level, is the major adverse postoperative event associated with a troponin rise. So that implies the fact that although those patients have manifested themselves clinically as being stuck on a ventilator or having sepsis or a pneumonia, they've also had an indicator of myocardial injury. And I think that sort of makes sense to me. That's beginning to pull together. So how that helps us next week, I'm not sure. But I think...
That's what I was just going to ask. What are we thinking that this is going to... how we're going to, utilize this in practice tomorrow?
Well, I think they're fairly insightful at the end of it. You can hear me turning the pages to that. Is it, if I go to the conclusion, I think the conclusion is really saying, well, I don't think we know what to do about that next week yet. It says the investigation suggests that if the myocardium is injured, as evidenced by troponin elevation, then it likely does not possess the reserve to cope with short-term and long-term stresses of surgery, i.e., I'm taking from that if you have a major post-operative complication and you're seeping out troponin because your heart's now working hard and it can't keep up, you're much more likely to die. A body of evidence now exists showing that clinically silent troponin elevation after surgery signals significant increase the risk of adverse outcomes immediately and less than 1 year after surgery. Studies on the etiology, prevention and treatment of myocardial injury are needed. And yeah, I sort of get all of that, but the main thing that screams out to me is that overlap with the MET study. I mean, the MET study, the main takeaway I got from the MET study, and so you can listen to the interview with Mike Grocott on the Top Med Talk all about the MET study, is that the cardiopulmonary exercise testing was the best independent predictor of developing these types of major complications. And the cardiopulmonary exercise testing tells you your heart can't do much to keep up. So it seems to me that if as they're alluding to here, that the myocardium is injured as evidenced by the troponin rise, that it does not possess the reserve to cope. These sound like the same signals to me. That's what I don't know what to do about it next week, but I agree it needs further investigation.
Yeah, for sure. Maybe think twice before you recommend surgery for something.
Well, perhaps based on that results, but I think it's really it's a complicated read, but I think it's worth having a good look at. It also gives us some ideas of the numbers involved, the incidence of these various different complication rates. It's a huge cohort, very high quality data. So I encourage everyone to read it. It's actually a great edition of Anaesthesia and Analgesia. It covers a lot of what we've been covering in Top Med Talk. It goes into multimodal anaesthesia. It has a very challenging article about whether or not IV paracetamol helps. It's got some great infographics in there. And it also deals with something that we picked up on Top Med Talk over the year, which is the relevance of oliguria, and an article in here that reinforces the idea that perioperatively, a urine output of about 0.5 ml per kilo per hour is worth taking seriously. So I think well worth having a flick through. Well, they're always worth having a flick through, but lots that's interested me in the November edition of Anaesthesia and Analgesia. Is there any other questions or comments about any of that? I'd encourage you to have a quick look at the IV paracetamol one, because it's quite challenging about whether that's helpful or not.
Yeah, I definitely have, especially in spine surgery, yeah?
Absolutely. I think we're going to have a closer look at that. Yeah. We'll do a journal club about that one as well, but we're out of time on this one. Desiree Chappell, thanks very much for joining in. I hope that helped, and thank you everyone for listening to Journal Club. Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.